Now, today we'll be talking about one of the most important clinical aspect, that is sepsis. Now, sepsis is extremely common thing that we see in day-to-day life. Now, we must know to label it as sepsis, it is basically the infection, which is the first thing which has to be there. And there is an inflammatory cascade or inflammation which sets in, and this inflammation then gets so much overwhelming so that the usually SIRS, that is systemic inflammatory response syndrome, sets in, and this overwhelming inflammatory cascade gets out of hand from our inflammatory system. That is what is which causes multi-organ dysfunction, which mainly involves kidneys, lungs, heart, and each and every system of the body, and most of the time it is lethal to the body. Now, what is SIRS? SIRS is systemic inflammatory response syndrome, which has to have these four criteria. The temperature has to be more than 38, or it has to be less than 36 degree. The heart rate has to be more than 90. The respiratory rate should be more than 20, or the patient should be on the ventilator. And the total leukocyte count should be more than 12,000, or should be less than 4,000. Now, how to diagnose sepsis, or when to label it as sepsis? For that, we need two criteria. Either there should be suspicion of infection or proven infection, and at least two of the SIRS criteria should fit in among these. Now, suspected or proven infection can be like, it can be pneumonia, it can be urine tract infection, it can be pyelonephritis, it can be abscess anywhere, it can be cellulitis, it can be diabetic foot. So it can be any infection that is either suspected or proven by the laboratory investigation, and it should be present with at least two of the SIRS criteria. Now, when do we label it as severe sepsis? We label it as severe sepsis when sepsis means these two criteria, plus there is multi-organ dysfunction or involvement of more than one organ. And when we call it as septic shock, whenever there is sepsis and hypotension, that is mean arterial pressure, it should be less than 65, or usually if the systolic blood pressure is less than 90, or if the patient has oliguria or acute kidney injury, we call it as patient has septic shock. Now, very commonly, this multi-organ dysfunction, what does or how does it involve? So, for if you consider liver, is very commonly what we find is there will be derangement in SGOT, SGPT. Usually, they may not be more than three times the normal SGOT, SGPT levels, but very commonly there can be increase in total bilirubin levels. The INR may be deranged commonly, or the APTT may be deranged very commonly. For like kidney, the patient may have acute kidney injury. There can be increased levels of blood urea nitrogen. The patient may have reduced urinary output, or the patient may have significantly urine output, reduced output, so that they may land up in acute renal failure as well. For like heart, the patient may have hypertension. Very commonly, the patients have tachycardia because of the inflammatory system, inflammatory response, and the patient may also have bradycardia because of excessive inflammatory stimulation. In blood, very commonly, what we get is the patient may have anemia. The hemoglobin, there may be drop in hemoglobin like 2 to 3 grams. Thrombocytopenia is very common, and it can be less than 1 lakh, 70,000, 80,000, and it may fall up to 20,000, 10,000, depending on extent of severe sepsis. Acidemia is very commonly a found problem. So any patient who has sepsis, ABG or VBG is very commonly done to see the bicarbonate levels, to see the pH level, and the treatment can be given accordingly. Hypoxemia, because of the involvement of the lung, as well as there is extensive use of the oxygen by our immune system as well as by the bacteria in various processes, which leads to hypoxemia. Leukocytosis or leukopenia, both things are extremely common in sepsis. In fact, if there is severe leukopenia or if there is severe leukocytosis, very commonly sepsis is usually suspected. For lungs, the patients may have Krebs, patient may have wheeze, patient may have rhonchi, patient may have repeated bronchoconstriction, so patient may need acetylene, Duolin, Budecort, Foracort, salbutamol, salmeterol, nebulization or inhalation very commonly because of the inflammation. It very commonly precipitate the bronchospasm. Hypoxemia can be very much commonly present. The patient may need a ventilator, the patient may be on non-invasive ventilator or invasive ventilator, and tachypnea is very, very commonly associated with sepsis. Now, while this sepsis is so bad, we must know the sepsis is usually caused by the organism. Most of them, they are either gram positive or gram negative, and less likely they can be fungal or viral. So what commonly happens is in sepsis, there is huge increase in the number of this gram positive or gram negative or fungal organisms, so that they cause extensive endothelial damage, which releases significantly increased levels of inflammatory biomarkers like interleukin 1, interleukin 6, interleukin 8, immunogenic factors, cytokines, chemokines. So there is huge and huge chemical burden which is there in the blood. And to control this, all these chemicals in that much of huge extent, the our immunity gets unregulated, so it becomes disastrous and it is so much harmful, so that it causes multi-organ dysfunction, and it may lead to death of the patient if it is not appropriately treated at appropriate point of time. So, what are the common microbes which commonly causes sepsis? So, in gram-positive bacteria, Staphylococcus aureus, Coagulase negative Staphylococcus, Enterococci. In gram-negative bacteria, very commonly E. coli, Klebsiella, Pseudomonas, Acinetobacter. They very, very commonly cause sepsis. It can be UTI, it can be acute gastroenteritis, it can be pyelonephritis, it can be pneumonias. And in fungi, Candida is one of the most common culprit for the severe sepsis. Now, when to suspect sepsis, or when to think of that again this patient may have sepsis. So any patient, for like in if we consider like lung signs, if the patient has cyanosis, tachypnea, so much of expectoration, hypoxemia, or if the saturation is less than 90%. Cardiac wise, if the patient has any patient who has hypotension, or if any patient, if they need vasopressor or inotropic support to maintain the hypotension or to treat the hypotension, we should always suspect sepsis. Any patient presenting with pulmonary edema, because sepsis may push the patient to the pulmonary edema. Patient presenting with or having arrhythmias, or if there is persistent tachycardia, we should definitely suspect sepsis. For kidney, like if the patient has oliguria, or if the patient has acute kidney injury, if the urinary output is less than 0.5 ml per kg per hour, that is half the weight of the patient. If there is raised serum creatinine or blood urea, or if the patient is in acute renal failure, if the patient has persistent acidemia, this is very, very important, which we can see on ABG or VBG, or if there is increased base deficit, we should always and always suspect sepsis. If liver biomarkers, if they shows persistently elevated SGOT, SGPT, or there is deranged INR, or if the patient has flapping tremor, encephalopathy, or increased bilirubin, we should think maybe the patient has sepsis and we should evaluate in that way. For blood parameter, if the patient has bruising, persistent anemia, or if the patient's D dimer is very high, if the patient has leukocytosis, leukopenia, thrombocytopenia, or increased lactate dehydrogenase, or if on the smear, if the report says that there is presence of toxic granules in the neutrophils, then these things or these findings may also suggest that the patient may have sepsis. We should always think of sepsis. For gut wise, if the patient has anorexia or paralytic ileus, or if the patient has vomiting, nausea, this paralytic ileus you have to always consider in any post-operative patient. If the patient is not improving, if the patient has persistent tachycardia, tachypnea, or paralytic ileus, then the patient may have landed up in sepsis, which is a very common thing, and we should always and always suspect. Endocrine wise, if the patient has hypoglycemia, multiple episodes of hypoglycemia unexpected, or if there is huge hyperglycemia, if there is weight loss over a period of 15 days, 20 days, then we should definitely think of sepsis as an underlying cause of worsening. Brain wise, if the patient is confused, if the patient has delirium, if the patient has encephalopathy, or if the patient is presenting with convulsions or coma, we should always suspect sepsis. Now, how to treat it? First, we have to identify. First, we have to suspect, and then we have to identify. We have to diagnose that yes, the patient has sepsis. In most of the patients will definitely need so much of antibiotics, IV fluids, sodium bicarbonate, inotropes, vasopressor, blood, crystalloids. So there will be a lot of things which the patient will be receiving. So if it is possible, then central lining is always beneficial because it can provide the medicines at a higher possible rate. At a time, 2 to 3 to 4 medicines or more than that can also be given. So central line should be put if it is possible. The target of the systolic blood pressure should be at least more than 100 millimeters of mercury so as to maintain the urine output at least more than half of the weight of the patient. If the weight of the patient is 80 kg per hour, at least 40 ml should be the output. That is bare minimum. One of the most important thing in this septic patient is hypotension. So IV fluid should be definitely given or corrected if the patient is dehydrated. Now, how to look for dehydration? The patient may have dry tongue. The patient may have dry skin. You can go for 2D correlated IVC measurements. If it is less than 18 millimeters, you can say that there can be scope for hydration. If the IVC is very much thin or collapse like 2 millimeter, 3 millimeter, 4 millimeter, 8 millimeter, 12 millimeter, then the patient is severely dehydrated and we can give IV boluses of 300 ml, 400 ml, 500 ml also to hydrate the patient and to maintain the blood pressure. If IVC is more than 18 millimeter and if the collapsibility of IVC is less than 50%, then we say that the patient is well hydrated. So fluids, they are very important, particularly if the patient is dehydrated. As we hydrate a patient who is dehydrated, very commonly the tachycardia usually settle down over a period of time. So as soon as we start fluid to a dehydrated patient, the patient with tachycardia having heart rate of around maybe 116, it should start reducing down to 114, 112, and over a period of few hours, maybe 6 hours, 8 hours, after proper hydration, the heart rate may settle to around 100 or 102 or 103 like that. So tachycardia very commonly improves with proper hydration. Excess of fluid can definitely end up the patient in fluid overload, so we have to be very cautious. Fluid overload status can be evaluated by presence of edema, presence of oozing, or if there is accumulation of the fluid in the lungs, very commonly the patient will have hypoxemia, tachycardia, or tachypnea can accompany. So if there is drop of saturation from like 98 to 93, it may mean that there is accumulation of the water into the lungs. So we always have to hydrate and we always have to monitor hydration with saturation. And we should always keep on auscultating such patients for presence of wheeze, presence of crypts, or presence of rhonchi, which may appear because of the fluid overload state. So we should always look for the respiratory rate, that is tachypnea, tachycardia, and increase respiratory muscle use. So with fluids, usually blood pressure gets stabilized, the heart rate gets stabilized, and urinary output improves. So if the patient is dehydrated, then you can see a concentrated dark yellowish urine. So as you hydrate the patient, the color of urine fades away or it gets lesser and lesser concentrated. So it may appear much cleaner after proper hydration. Usually, to start with, any patient who has sepsis, usually they need around 3 to 5 liters of fluid resuscitation. So that can be given like 500 ml, 600 ml NS or RL, depending on what fluid is given. And after that, it can be continued at 100 to 120 ml per hour for a few hours with the monitoring of heart rate, saturation, blood pressure, Krebs, and a respiratory rate. After once this 3 to 5 liter fluid resuscitation is given, the fluid can be continued at 40 to 60 to 80 ml depending on the weight of the person. Now, the next important thing is vasopressor. So in vasopressor injection, noradrenaline is one of the best vasopressor. Why? Because it won't cause heart rate change usually. It won't cause tachycardia. It won't cause much bradycardia. It will definitely increase the systolic blood pressure. And the risk of arrhythmia is much lesser with noradrenaline. It is very easily available and very cheaper. The second best vasopressor is vasopressin because it also won't cause much heart rate change, but it usually causes intense vasoconstriction. So ischemic hepatitis uh, can definitely lead. And if the patient is post-surgical, so such patients will have wounds, suture lines, multiple lesions, or skin which is sutured, or gut or anastomosis which are sutured. So vasopressin can lead to poor surgical wound healing or poor anastomosis healing. So this is one problem with vasopressin. But whenever the hypotension has to be corrected, it has to be corrected. There is no way. So if the patient is on noradrenaline and if the blood pressure is not sufficiently maintained, vasopressin has to be the second drug which has to be started. Injection dopamine can be given, but we must know dopamine causes significantly increase in heart rate. So the risk of arrhythmia, the risk of SVT, VT, ventricular fibrillation is very high. And that is the reason why it can be ideal inotropic drug for the patient who has bradycardia. Dobutamine, it is one of the excellent inotrope, but it is usually only considered, or it is ideal only for those patients who have heart failure with reduced ejection fraction. So it increases the contractility of affected heart, the heart which is weak, which is not able to pump well. That pumping capacity can be used by increased by dopamine. So it is used for those patients who usually have heart failure with reduced ejection fraction to improve the uh, urinary volume or urinary production. So as this also increase the heart rate, it can also cause arrhythmia. So dopamine or dobutamine, if they are used, they should be used in low dose. If it is used in high dose, then arrhythmia risk like supraventricular tachycardia, ventricular fibrillation is very, very high. The most important aspect for sepsis is appropriate antibiotic. So whenever we are starting the antibiotic, it is always better to send a blood cultures or urine culture, depending on what is the suspected or proven cause of infection. If the patient says urinary burning, it can be very highly urine tract infection. So urine culture must be sent. If the patient has cough expectoration, then it can be pneumonia, it can be community acquired pneumonia, it can be hospital acquired pneumonia, it can be ventilator associated pneumonia. So sputum culture sensitivity or ETT culture sensitivity should be always sent. If the patient has a wound, a lesion, a cellulitis, then the pus culture sensitivity must be sent. So whatever secretions or whatever the thing is involved, that should be sent. It should be always tried to send it first before starting the antibiotic. If it is not possible, the antibiotic should be started right away so that the patient gets benefit and patient start getting better. It should be always a broad spectrum antibiotic plus an antibiotic which can give good gram positive coverage, or with antibiotic which can give good gram negative coverage. And if it is needed, the antifungal can be added, especially for those patients who are bedridden, those patients who are chronically diabetic, or those patients who have cancers, or those patients who have so much of lines, intracats or Foley's or central lines. So in such cases, antifungal should be definitely considered. Otherwise, routinely antifungal may not be necessary. If the fever doesn't get settled, even with proper antibiotics, then antifungal must be always considered. So a broad spectrum antibiotic can be third generation, fourth generation cephalosporins. What commonly antibiotics are used are like piperacillin, tazobactam, meropenem plus or minus sulbactam, or tazobactam, cefeprazone plus sulbactam, or cefepime plus or minus sulbactam, like ceftriaxone plus sulbactam, with or without EDTA. So this addition of sulbactam or tazobactam may not be always there, or very commonly isolated meropenem is started, and if the patient develops fever or if the patient shows inadequate response after 2 to 3 days, then sulbactam can be added to the same meropenem to increase the efficacy of this meropenem and to decrease the resistance by these bacteria. So for gram-positive coverage, we can always consider linezolid or ticaplanin or daptomycin. For gram-negative coverage, we can always consider fluoroquinolones, like we have excellent levofloxacin, ofloxacin, ciprofloxacin, or in aminoglycosides, we can consider amikacin, kanamycin, gentamicin, but which are very commonly nephrotoxic, autotoxic, vestibulotoxic, even at therapeutic dosage. We can consider colistin, polymyxin, or aztreonam, which have very good gram-negative antibacterial coverage. And for fungal, most of the time, fluconazole is sufficient. If in a particular way, if we think the fungal infection can be aspergilloma or some other fungal infection, then voriconazole or micafungin or caspofungin can be considered. So How to come to know whether the patient is getting better or what is the current status of the patient? We can send the markers for the sepsis. So, if the patient is very unstable or if the patient is bad clinically from yesterday, it itself says that the patient is getting worse. So, unstable patient itself is a marker that the patient is bad or the patient is worsening. The clinical factors which may tell that the patient is in very bad condition compared to yesterday is tachycardia, increasing tachypnea, worsening oliguria or anuria, worsening weakness, worsening lethargy, persistent nausea, vomiting, fever, chills. Or if these symptoms improve, mean the patient is definitely getting better. If these symptoms worsen, it means the patient is getting worse. Then procal is one of the excellent marker of sepsis. I already discussed this in other video. Normally, procalcitonin is not found in the blood. So if it is less than zero point 0.5, we can say that the infection is very mild. If this procalcitonin is between zero point 0.5 to 2, we can say that the patient has moderate infection. And if it is more than 2, we say that the patient has severe sepsis. Then CRP, D-dimer, interleukin 6, these are the inflammatory markers which are called acute phase reactants, which remain very, very high in sepsis. So how do you come to know which are the markers which may show that the patient is getting better? This heart rate, respiratory rate, improvement in the blood pressure, improvement in the saturation, this automatically says that the patient is getting better. If these are worsening, then we say that the patient is getting worse. So presence of symptomatic betterment is definitely itself a marker of improvement. Presence of a better appetite from earlier itself is a marker of improvement. Presence of better urine output in a patient who had oliguria or anuria itself is a marker of improvement. And one of the best thing is key improving C-reactive protein, improving D-dimer, improving procal. So these markers will be usually high in a bad patient or in a severe sepsis patient. Suppose the CRP can be 226. On the next day, it can be like 160. The next day, if it is like 80, it means the patient is getting much, much better. Procal, procalcitonin, if it is suppose 23, if we repeat it after 2 to 3 days, and if it becomes 41, it means the patient is worsening. Or if the procal was like 41, and after 2 to 3 days, if we repeat it, and if the procal is from 41 to if it is 13, it means the patient is improving infection wise. And if the patient shows clinical betterment after 5 to 7 days of antibiotic course, then we can do the antibiotic de-escalation or reduction of the antibiotic dosage, or we can change to a lesser, stronger, cheaper antibiotics. Or if the CRP, C-reactive protein, or procal shows marked improvement, we can de-escalate the antibiotics. Apart from these things, we should always consider in sepsis, hypoglycemia is very common. So injection 25% dextrose should be definitely given whenever there is hypoglycemia. DNS can be continued if there is persistent hypoglycemia for temporary period. We have to make sure that the patient doesn't land up always in severe hypoglycemia. For hypertension, we should always keep on repeating ABG or VBG to see metabolic acidemia. Normally, the bicarb levels will be in between 22 to 26. If it is less than 22, and if the patient has hypertension, we should always consider giving injection sodium bicarbonate. The only problem with sodium bicarbonate injection is the patient may land up in fluid overload. So by that way, we can reduce injection NS or RL, whatever other fluid we are giving, and in that place we can give injection sodium bicarbonate. If if the bicarbonate levels in the ABG or VBG is less than 14, then we can continue injection sodium bicarbonate at 25 to 50 cc per hour also to fight off the hypertension temporarily till the antibiotic take good effect, till hydration take good effect, and the hypertension can be managed. If the hemoglobin level is less than 7 to 8, then we can consider giving blood transfusion just to keep the hemoglobin level between 7 to 8. More than 8, if hemoglobin is there, there is no much benefit of giving blood transfusion. If the patient has hypoxemia, or if you consider better wound healing, then instead of giving NS or RL in 300 ml, 500 or 600 ml, we can simply consider giving 1 BT so that it can improve the wounds, and we can target the hemoglobin of up to 8 to 10 as well if there is wound healing is the concern, or hypoxemia is the concern, or if there is persistent tachycardia, so that to improve the oxygen delivery. Steroids. In severe sepsis, if the patient only has hypotension or shock, then injection hydrocortisone 100 milligram can be given 3 times a day to tackle the hypotension problem, because in severe sepsis, because of the persistent inflammation, persistent tachycardia, very commonly there will be deficiency of mineralocorticoids because of excessive tachycardia or high tachycardia. So the body may have temporary deficit of mineralocorticoid. By giving these steroids, we give that deficit, we give that mineralocorticoid activity, so that the blood pressure can be maintained. These can be given to maximally for 5 days. More than 5 days, there is no much benefit of steroid, and they should be definitely discontinued. As soon as the blood pressure is maintained or the hypertension improves, the hydrocortisone should be discontinued. So even after 2 days, if the blood pressure settles, then after 2 days also the hydrocortisone should be discontinued. The problem with the hydrocortisone is hyperglycemia. They'll cause increased blood sugar levels. They'll increase the skin friability. So ecchymosis, wounds, these problems will be increased with steroids, and they very commonly hinder wound healing. So surgeons very commonly avoid giving steroids if there is suppose anastomosis or skin suturing, because the wound healing will be delayed because of the steroids. And definitely, as hydrocortisone has mineralocorticoid activity, it can cause sodium and water retention, and the patient may end up in fluid overload or pulmonary edema. So this was all about severe sepsis and sepsis. Hope you like it. Thank you.